Good evening and welcome to the 13th edition of the ERS Vision Live panel discussion featured exclusively on the ERS Respiratory channel. Today's discussion will focus on the management of sarcoidosis. The talk will be broken down into three parts in which the panel and speakers will discuss difficult issues in the management of cardiac sarcoidosis, who should be treated in sarcoidosis, risk stratification and quality of life issues, and finally, treatment regimens in sarcoidosis, what to choose, and related issues. We are delighted to welcome today's panel, led by Professor Athol Wells and Dr. Elizabeth Renzoni. Athol Wells is a consultant chest physician at the Royal Brompton Hospital. He has broad ILD research interests covering clinical science and translational research. He is also a member of the Fleischner Society and president-elect of the World Association of Sarcoidosis. Elizabeth Renzoni is an ILD specialist working at the Brompton Hospital. Her key clinical interests include sarcoidosis, idiopathic and connective tissue disease-associated ILD, and hypersensitivity pneumonitis. Her key research interests include prognostic and outcome biomarkers in lung fibrosis across ILD entities. She has participated in several recent clinical practice guidelines and is an associate editor for Respirology. Good evening, Professor Wells and Dr. Renzoni.
Thank you, Maeve. Good evening to all.
Good evening.
Thank you for co-chairing this event. Joining us to help understand the first topic of discussion, difficult issues in the management of cardiac sarcoidosis, is Dr. Vasilis Coronas. Vasilis Coronas is a consultant respiratory physician at the Royal Brompton Hospital and honorary senior lecturer at Imperial College, London. He is actively involved in clinical research, and as part of his research activities, he has co-designed and participated as principal investigator in clinical trials in treatment of pulmonary and cardiac sarcoidosis. Good evening, Dr. Coronas.
Good evening. Thank you for inviting me.
It's lovely having you here with us. So to start this section off, it is generally acknowledged that management decisions are difficult in sarcoidosis. There is a lack of controlled data and considerable variation in treatment regimens. We would love to hear what you have to say about this.
I think I agree with you that treatment in sarcoidosis is challenging. However, now we have data to support that the indications for treatment can be easily summarized into two major categories. One is treatment focusing on major organ involvement, which is associated with a higher risk of mortality or permanent disability, or targeting unacceptable loss of quality of life. And what can be clearly be understood from that is that decisions related to major organ involvement and risk of mortality associated with that are based on medical expertise and supported published evidence, whereas in interventions to address quality of life, we require active patient engagement, both for the decision to institute treatment, but also change treatment accordingly to improve their symptoms. In cardiac sarcoidosis in particular, when we have major organ, it is a form of sarcoidosis with major organ involvement, and evidence of active myocardial inflammation indicates vigorous treatment to prevent any disease progression and often change the natural disease history. I think that we have to remember that treatment should be continuing for quite some time because relapses can occur. And we should never forget that comorbidities are always playing a role in every sarcoid patient. Therefore, treatment should be adjusted according to that. We have the luxury to use steroid-sparing agents to allow the steroid dose reduction, which seems to be mostly associated with side effects.
So Vasilis, just to extend you a little, is pharmacological therapy always required in cardiac sarcoidosis? And if not, how is this decision made? I'm talking about decisions to introduce therapy.
Thank you, Athol. Cardiac sarcoidosis is by definition a major organ involvement of sarcoidosis. And we have seen that patients may have treatment applied to them even without any justified evidence. However, what is important to understand and what I would highly recommend is multidisciplinary evaluation of each individual patient, which would give us a clear indications for treatment. The symptoms at presentation, often electrocardiographic abnormalities, the extent of myocardial damage and morphological changes on imaging modalities, as well as any evidence to support myocardial inflammation are key to drive the decision in cardiac sarcoidosis. We have seen we should be treating patients with active myocardial inflammation quite vigorously, and steroids remain the cornerstone of treatment. But on the other hand, patients with burned out cardiac disease, some of which can have limited myocardial scarring and lack of any inflammation, should be observed. As you have introduced the term of mycotherapy, masterful inactivity with cut-like observation, it seems to be the most appropriate option for these patients.
Okay, so again, just to take you a little bit further, if you are introducing therapy, what should the initial treatment consist of? And can you speak to low dose versus high dose therapy and with what drugs?
So as previously mentioned, I think that there is no evidence-based answer regarding the optimal pharmacological therapy in cardiac sarcoidosis. Again, I would emphasize on the multidisciplinary approach for treatment in this particular group of patients. Therefore, the intensity of myocardial inflammation, the module of the original disease presentation, whether this is arrhythmia, heart failure, or an incidental finding, and the extent of myocardial damage would determine the intensity of immunosuppressive therapy. I think that we all need to keep in mind that the main target remains to prevent further worsening rather than achieving complete reversibility in patients with cardiac sarcoidosis. In most centers, including ours, corticosteroids remain the cornerstone and first-line treatment in patients with cardiac sarcoidosis. And we have chosen to treat our patients with even intravenous methylprednisolone infusions for 3 consecutive days, as opposed to high oral steroid dose. We have seen that such approach results in better control of the disease while we minimize the side effects of the long steroid treatment in the long run. Our target is to take control of the inflammatory activity, and that may indicate the use of steroid-sparing agents, where methotrexate appears to be the most often chosen agent. The decision would be made on a case-by-case basis. In other patients where we don't have high risk or there is only low-grade myocardial inflammatory activity, oral steroid dose may be chosen. I think that it is important to know that we shouldn't fall into the trap of treating tentatively due to concerns about steroid therapy, because this can result in increase overall of the average steroid dose for a long time,
without, in fact, adequate control of the disease being achieved. I want to now switch the focus slightly to a question which has been something of a moving target. When should an intracardiac device be inserted?
I think the intracardiac devices are related to our ultimate priority, which is the patient's safety. And we know that cardiac sarcoidosis is associated with a high risk of sudden cardiac death. According to the international guidelines, we know that an implantable cardiac defibrillator is recommended in all patients who either present with sustained ventricular tachycardia causing hemodynamic compromise, well known as a cardiac arrest, or those patients who have a severe heart failure and ejection fraction below 35% that fails to improve with standard heart failure treatment. In cardiac sarcoidosis, we often see patients presenting with conduction abnormality and most likely anteroventricular block, and therefore there is a need for pacing. In these particular patients, we tend to implant an ICD rather than a pacemaker because the risk of life-threatening arrhythmias down the line during follow-up is high. Then we have a group of patients that has been most recently acknowledged as being high risk of sudden cardiac death that does not fulfill the criteria for either pacing or an ICD implantation. And these patients should be evaluated in a multidisciplinary approach and basically evaluate their extent of myocardial damage and LV dysfunction. In these particular patients, we often decide about implanting an ICD as secondary prophylaxis based on multidisciplinary discussion.
So in point of fact, this applies to those patients sometimes with ejection fractions over 35%. And can you say something to close this question on how you then make the judgment on myocardial damage in the setting of, say, an ejection fraction of 35 to 40%?
I think that it is very important to integrate the imaging modalities in that case. And we know from the international guidelines from cardiology that the extent of lead gadolinium enhancement on cardiac MRI is usually the core marker to determine whether these patients are high risk. We have also seen in our institution that the BNP or NT-proBNP appears to be a very useful biomarker in determining which patients are at higher risk with LV dysfunction. Therefore, I would strongly recommend evaluating these parameters. Finally, I would like to say that patients with active myocardial inflammation and LV impairment are obviously at high risk, and this has been shown by several studies. So presence of inflammation plays a key role in the assessment of these patients that do not fulfill completely the ICD criteria.
So I'm handing over to Dr. Renzoni.
Just as you're speaking about cardiac inflammation, one of the questions that has received the most interest is how do you optimally test myocardial inflammation? And also, what is the optimal MDT team approach? What is your optimal MDT team for diagnosis of cardiac sarcoid?
Thank you, Elizabeth. I think that the core modality to address the question about myocardial inflammation in the heart remains the PET scan. And obviously, it is a new modality, and we are learning still from it, but it is definitely the best tool to address the question as to whether there is evidence of myocardial inflammation. Often a patient with known sarcoidosis presentation with complete heart block should mean that there is evidence of activity, and also in patients with cardiac sarcoidosis, unacceptable loss of quality of life is often associated with disease activity. However, I would opt to use PET as my core marker of activity. I would like to add also that there is evidence about biomarkers such as high sensitive troponin that in some patients could address the issue regarding activity, which is the primary target for all the sarcoidosis experts dealing with the disease. Regarding the MDT structure, I think that we are following the example of interstitial lung disease. And we have definitely the need for assessment of the morphology of the heart, and that is best addressed by the cardiac MRI, as this appears to be a superior tool compared to echo. Then we want to address the evidence of tissue, we want to address the tissue characterization, and therefore we want both cardiac MRI and cardiac PET to answer us about presence of myocardial fibrosis and or inflammation. So a nuclear medicine consultant and a cardiac MRI expert in cardiac sarcoidosis are definitely required to support the clinicians that are usually a sarcoidosis expert and the cardiologist. And we have seen that exchanging ideas between two different clinicians has resulted in improvement of and more accuracy in our decision-making.
Thank you very much, Vasilis. That's very useful. I have a series of questions on treatment. Let's say one question is about how long the minimum duration of treatment with steroids should be, and what are your thoughts when you're thinking about introducing second line or third line? What do you think about steroid resistance? So trying to combine the various questions I can see on treatment.
I think that we don't know the exact duration of immunosuppressive treatment in cardiac sarcoidosis, and we have seen one paper published showing that withdrawal of steroids has resulted in major adverse events during follow-up. These patients were not actually evaluated as to whether there was any relapse of their disease down during follow-up, but it is appropriate to remember that. So I would say that we would consider treating these patients as a bare minimum of 2 to 3 years, but in reality, there is a high possibility that these patients are treated lifelong. I would say that the decision regarding introducing a second-line agent highly depends on the patient's profile. As I mentioned before, symptoms of presentation, ECG abnormalities, and extent of damage play a role. We know that patients with severe heart failure, so an ejection fraction below 35%, are at major risk, and therefore over-treating these patients may not be something that would cause any reversibility. On the other hand, patients with conduction abnormalities, there is a possibility of even reversing these changes. So I would say that I would strongly consider adding a second-line agent when there is evidence of high level of inflammation on our testing. I would use a steroid-sparing agent when I can see that the steroids cannot be reduced below 10 milligrams of steroids and there is still evidence of activity. And I would try to take the dose of treatment to the level that the disease is controlled. The only last comment I would like to make is that obviously dealing with cardiac sarcoidosis has led me a lot, and there are a number of cases that are refractory to treatment, conventional therapies such as steroids and methotrexate or azathioprine. Therefore, we have often used anti-TNF therapy with good success in our population, and this should be considered in refractory to conventional treatment patients.
Thank you, Vasilis. I don't know if we have time for a final question, but just a 30-second answer, and that is, how do you follow up treatment efficacy?
So I would say that I would repeat the PET scan in 4 to 6 months after vigorous treatment initiation. So in patients with a lot of myocardial inflammatory activity, in patients who are long-term monitored, I would tend to use an imaging modality, either an MRI or a PET, every 12 months. And especially if there is any treatment change from an immunosuppressive perspective, I would use a PET scan to evaluate any relapse of the disease. The echocardiogram, especially in patients with a device in place, is appropriate, and we tend to use BNP in all our patients as a marker during monitoring.
Thank you very much. There are a lot more questions, but we're going to have to move on. And I pass over to Maeve again. Thank you, Vasilis.
Thank you, Dr. Renzoni. And now to the next topic of discussion: who should be treated in sarcoidosis, risk stratification and quality of life issues. We welcome Dr. Marlies Weichenbeck. Marlies Wezenbeek is chair of the Erasmus MC Multidisciplinary Centre of Interstitial Lung Diseases and Sarcoidosis, ILDS. Her research interests include patient-centred outcome measures in ILDS, e-health and new therapies in pulmonary fibrosis and sarcoidosis. She is also the ERS Group Chair 12.1 and Associate Editor of the European Respiratory Journal. Good evening.
Good evening, Maeve. Hi.
So, to start this section off, there has been considerable confusion over the decades as to broad treatment indications in sarcoidosis. Some clinicians have treated all patients, others have been guided by long lists of treatment indications. So we look forward to hearing what you have to say about this, Marlies, and the floor is yours.
Thanks, Maeve. I think this confusion is understandable because it's not so clear-cut. Sarcoidosis is a very heterogeneous disease, so I think making treatment decisions has always to be individualized and tailored to the specific patient.
Thank you, Marlies. Hi.
Hi, Elizabeth.
So,
Good to see you.
hello. Lovely to see you. So again, I guess the same question as for Vasilis, but in this case, generally in the treatment of sarcoid, how do you see the broad indications for a sarcoid patient in pharmacological treatment?
I think it starts with what Vasilis also already told. You have to assess the risk of an organ failure or death for the patient, and also a second treatment indication would be severe impairment of quality of life. So this means that if you see a patient, you have to make an estimation on what you expect for the risk of the patient, take into account the disease burden, how you expect it to evolve, and also the wishes of the patient, obviously, and the aims of the patients. But I think it is also good to realize that there is a large group of patients that don't need treatment in sarcoidosis, and that they have a more benign form that has a high risk of spontaneous resolution. But I think in the patients that do need treatment, you really have to realize, and Vasilis also said that adequate and timely treatment will stop further deterioration of the damage and even will resolve it in some cases. So I think this is something to balance. And if you look at these treatment indications, it's often pulmonary and cardiac. We just heard extensively about that, but don't forget about other organs. Neurological threat can be also severe and needs treatment, but also renal failure or eyes can have really significant morbidity. So don't forget about these treatment indications. And if you look at the quality of life issue, quality of life can be impaired, for instance, because you have severe lung function impairment and are short of breath and cannot do something. But I think we all recognize also these patients that have fatigue, pain, while they only have minor or no organ involvement. And that may be also an indication to treat patients. So I think in practice, in cases of clear danger to the patient for the organ or life-threatening, I'm very persuasive that we should go for pharmacological treatment. In this more gray area of impairment of quality of life and non-organ involvement complaints, it's more talking with the patients and balancing the pros and cons of treatment.
Thank you, Marlies. And just to draw you out a bit more on that, how do you identify in the different organs dangerous disease? How do you have... Can you tell us more about that?
Yes, I think it is not always clear-cut. There's a gray zone, but the most important thing is, I think, getting a full picture of the patient. So which organs are involved? How much are they impaired? What are the changes of spontaneous resolution? What is the burden of disease for the patients? But also, what are treatment aims and wishes for patients? And we have we find some literature and data on, what features are associated with worse outcomes. So we know that patients that have a disease onset above 40 that is associated with more chances of chronic and worse outcome, but also having a black skin, severe lung function impairment, the presence of pulmonary hypertension, and like we heard, the cardiac and neurological involvement, but also bone and renal involvement. So those are all features. If patients have those, you know that the outcomes for these patients are more likely to be worse. But it's not always clear. If, for instance, if we look at the lungs, I'm a pulmonologist. For one patient, an FVC of 85% and 65% may be a major loss and a threat. If you started off at 120% last year and lost all of this in 1 year and have severe abnormalities, this definitely is a treatment indication. On the other hand, if you have the same lung function, but this is already stable for years, you have minor abnormalities, this might not be a treatment indication. So that is also, I think, why the guidelines so far never gave very hard numbers on this is the range of lung function that you should treat. It always has to be seen in the context. And another complicating factor is that severe impairment does not always equal active disease. So especially in the more fibrotic patients, it is important to see if there is disease activity and what you expect from immunosuppression. And if you want to give that. So I also try to get a broader picture on that, for instance, by using biomarkers or even a PET scan to see if there is disease activity.
Thank you. And finally, and I know this is a particular area of interest of yours, what about non-pharmacological management of patients with sarcoidosis?
Yeah, I think this is very important, especially because not all patients need a pharmacological treatment. And I think the first thing is education, telling them about the disease, acknowledging that the complaints that they have are, real and realistic, and that more patients also struggle with this, and also what to expect for the future if you can counsel them on that. I always try to refer patients also to support groups because it helps to talk with other patients and who have experiences. Physiotherapy or physical or pulmonary rehab may help in some patients, but others may be too fatigued to do that. We have some good results with mindfulness-based cognitive therapy for fatigue that might help. A psychologist may help patients in dealing with the disease with coping strategies. But I also think we have to think about comorbidities. If patients have obstructive sleep apnea, you have to refer them to a sleep clinic. And I think we should not forget also the patients with very severe impairments that you can think of oxygen use or even referral to lung transplant. So I think there is a whole basket of measures, multidisciplinary, that you could see what fits for these patients and where can I help the patient and discuss with the patients what they also want.
So I think we can now take on various questions. And Marlies, I'd like to draw you out a bit more when you mentioned biomarkers in addition to PET, whether you would recommend any specific biomarkers.
Yeah, I think in some patients, what we use in our center a lot is the SGLT2 receptor. In patients that show that they had it elevated in the beginning, it might be a very good marker on how it lowers with suppression of the disease activity. It does not work for all patients, but I do think it can be quite useful in a group of patients. It's not a diagnostic biomarker, it's more for disease activity.
Understood. So you're talking about biomarkers that might drive your initial selection of therapy, but there's also a question here about markers that might be used to detect the risk of sarcoidosis deterioration. And I want to really ask you whether there is anything that you use both in untreated and treated patients predicting deterioration as opposed to identifying inflammation?
I think that is a good and tough question. There is some data, and you know well about that you can look at CT scan features of patients who are at risk for deterioration, so extent of fibrosis, the ratio of the diameter of the pulmonary artery, and you can make a score of that, a risk score, so see who does worse. So there are some tools to predict disease decline, but I don't think there is a perfect biomarker to predict this patient is gonna progress and that patient is not. We know features that are associated with risks, but I don't know how the others do that in their clinics. I would be curious to hear.
Okay, well, we may have time for broader discussion, but I see there are some good questions still that we will work through. So there's a couple of questions, Marlies, that relate to more severe fibrotic disease. There's a broad question, which is more of a statement than a question. So what about the more severe course of disease as in progressing fibrosis course of disease? I think you're being asked about the intensity of therapy, and you're also being asked whether you think any treatment works for the group that develop basal pulmonary fibrosis with honeycombing. And I suppose what we mean is a UIP-like pattern on CT.
Yeah. I do think it is important not to miss the opportunity to suppress inflammation that may drive this process. So what we do, we usually treat patients 2 or 3 lines, so steroid sparing, second line like methotrexate, and even upscale to anti-TNF if there's still activity. But here in this group, we particularly make PET scans to see if there is activity. We all know this small subgroup of patients with UIP in sarcoidosis. Is this a different entity in the sarcoidosis? Will they behave the same as IPF? We don't know. The data on anti-fibrotics in sarcoidosis are very limited. The inbuilt trial included only a very small group of patients, so that I don't think you can conclude on the separate population if anti-fibrotics will work. We do sometimes give it to patients that show progressive fibrotic disease despite optimal immunosuppression in sarcoidosis. I hope that answers the question.
Right. And I'm sure Dominique will perhaps pick up some of these themes. So we'll move to quality of life issues. There's a question about the prevalence of fatigue. And I think let's link that to another question about tools to assess quality of life in clinical practice and cutoffs using such tools. So what would you like to say about that?
I think fatigue is very prevalent. The intriguing thing is that it depends on which country you survey and if you ask it. For instance, in Japan, it seems to be less prevalent than in Europe, and even in Europe there are differences, but I think it is something we all recognize and all hear in our clinics. Tools to assess it, we use the fatigue assessment score. That is a very easy tool where we use a cutoff of 21 to say whether patients have, more severe fatigue or not. I'm not sure how much the use is to do that in every patient. It is, I think, good if you do interventions for a patient to follow up and see, if the therapy does something and to assess that. I think the same is for all these quality of life tools. It is a burden on your service. So if you have to do that in your limited time of consultation, that is not always feasible. But I do think it would probably help us guide our conversations and identify needs for patients.
Marlies, I'm going to ask you a question of my own. So I noted physical therapy may be of benefit for some patients, but others are too fatigued to even think about it. So can you speak to graded exercise as treatment for fatigue? Do you think it works in most people? What's your sense about its efficacy?
I think it depends also a bit on what sort of fatigue you have. Some people have a sort of deconditioning and inactivity and physical. So I think graded activity will work there. Other patients also have more coping problem, more psychological part of the fatigue, where I think probably more counseling and cognitive behavior therapies will work. So I think probably you end up in the majority of patients that a combination of both works most, whereas some patients will benefit more from more physical activity and others more from more psychological counseling, is my guess. But we never have in all these studies really stratified patients on type of fatigue and identified who would do best.
Yes, I've certainly seen patients who actually state firmly that graded exercise has worsened their fatigue substantially.
Yeah.
So I
Some
think
patients tell me.
you stressed at the start that it was one size fits all. Now we have several other questions, but I think reading them, some of them are actually more applicable to Dominique. So let me just instead ask you a little bit more about low versus high dose steroid and your approach especially to treatment of quality of life. So you've got a patient who doesn't have danger but has unacceptable loss of quality of life. How do you handle this? Doses, discussions?
I always start with non-pharmacological treatments, to be honest, but I do think some patients sometimes benefit also for fatigue or pain or general unwellness from systemic treatment. In that case, it helps to assess if there is activity of disease, and it also helps to talk with the patients that the medication side effects and burdens may also have a negative impact. So there is a good conversation. I would never give high doses of immunosuppression for that, and I would always start with a lower dose. And there is some limited data that a low dose might do something, for instance, on fatigue. I sometimes also go to drugs like methylphenidate to see if that helps for fatigue. But I do sometimes use medication for these non-organ specific complaints. And in some patients that works, but I always put strict evaluation and balancing side effects and effects.
Okay, you're doing very well in what is a sustained interrogation. But I think you've asked me this, and based on what Vasilis said and then what you said, somebody is asking whether every patient with sarcoid should have a PET scan.
No.
You want to expand at all on that reply?
Yeah, I think in the majority of patients, you don't need a PET scan. A PET scan is very good for cardiac sarcoidosis, and a PET scan is very good for when in doubt, when you have advanced disease, if there's still activity, and sometimes in the diagnostic process, when in doubt, where to biopsy and where to go. So I think it's definitely not something that we should do for all patients, not for burden on the patient radiation-wise, and not for healthcare system burden. So I think we have to be very selective with that.
Yes, and while we're on the subject of detecting inflammation, do you want to cover the issue of the BAL lymphocytosis? Do you find that a useful guide, and would you advocate ever repeating it?
I never repeat it, to be honest. I must say we have less BAL. I think many centers do it still in research setting, but since for diagnosis, we often go for the lymph nodes. There's many patients where I don't even have a BAL while having a diagnosis of sarcoidosis. But it does help if you have a pulmonary sarcoidosis and you have a high lymphocytosis. I would definitely consider that as an active disease. Yes, but I think we have less and less BAL in clinical practice, and I never repeat it. Except to rule out infections and malignancies. I would have to add that, but not for active disease activity.
Thank you very much, Vasilis. I think we now have to pass back to Naive to introduce the third segment.
Thank you, Professor Wells. Joining us for our final topic is Professor Dominique Valer, who will elaborate on the treatment regimens in sarcoidosis, what to choose, and related issues. Dominique Valer is Professor Emeritus of Pulmonology in the University Sorbonne Paris Nord and a pulmonologist in the Hôpital Saint-Joseph in Paris, France. He is involved in research on sarcoidosis and interstitial lung disease and was the co-chair of the recent ERS Task Force Clinical Practice Guidelines on treatment of sarcoidosis. Good evening, Professor Valer.
Good evening to all.
Thank you. So we will now discuss the treatment regimens with the intention of covering important decisions on choice and dose of therapy, including the use of second and third line treatments. Professor Valer, we look very much forward to hearing what you have to say on this topic.
As indicated by Marlies, there are two reasons to treat sarcoidosis. First, to avoid danger, i.e., mortality and morbidity risks. Danger may stem from pulmonary, cardiac, nervous system, or other manifestations. Second, to improve quality of life impairment when it is unacceptable. However, in 1/3 to 1/2 of patients, there is no reason to treat in the absence of danger or of quality of life impairment, and a follow-up is needed since in some patients, a progression of disease may need a delayed treatment.
Good evening, Dominique. The first question I have to put to you, can you outline the broad approach, choice of drug, dose of drug, in the initial treatment of dangerous disease?
Hello at all. For now, there is only one first-line treatment recommended, supported by evidence: corticosteroids. Oral prednisone or prednisolone is initiated at 20 to 40 milligram a day for 4 to 6 weeks, with further tapering doses up to 10 milligram a day as soon as possible, for a total of 6 to 12 months. A response is expected in a few weeks, but people with sarcoidosis need to be aware of adverse events with corticosteroids, the incidence of which increase with time. Information before treatment help to prevent them.
So that leads logically to the next question. How do you decide on second line and indeed on third line therapy?
A second line treatment, most frequently methotrexate given orally at low doses, 10 to 15 milligram once weekly, is usually proposed after a first course with corticosteroids for several reasons. First, unacceptable adverse events during corticosteroid treatment, mainly weight increase, high blood pressure, diabetes mellitus, mood swing, etc. Second, absence of efficacy. In this case, the observance of the initial treatment needs to be checked, as it can be a cause of treatment failure. Third, need to spare corticosteroid doses, the frequency of this condition increasing with time. A third-line treatment can be indicated in case of failure or bad tolerance with second-line treatment with preconization of anti-TNF alpha drugs like infliximab. The use of methotrexate and infliximab is supported using the GRADE approach. Other options may be proposed according to the task force experts of the ERS, but do not rely on the grade approach. Patients may be interested to participate to clinical trials, particularly in situations where evidence for proposed options is poor. The role of physicians is also to inform patients about trials available, criteria of inclusions, sites open.
So Dominique, the third question, and this has overlap with a question asked of Marlies, and I think it is good to have overlap for this particular question. How do you handle the pharmacological treatment of unacceptable loss of quality of life?
Quality of life has been shown a priority of patients in a recent study. However, validated quality of life scores are available only recently for sarcoidosis and have been rarely tested in clinical trials. For this reason, proposals are not supported by evidence and even do not reach unanimity among experts. In such context, a well-balanced dialogue is necessary between the person with sarcoidosis, a term preferable to sarcoidosis patient, and the physician. Often, the person with sarcoidosis will choose one or another option among those offered according to his or her preference. For example, wish of a rapid efficacy despite possible adverse events versus priority to avoid adverse events. In other words, higher doses of prednisone, 10 milligram day versus lower doses, 5 to 10 milligram day.
Hi, Dominique. Thank you very much. We're moving to the Q&A session. And for the moment, the question that has the most interest is, how long do you follow up patients requiring pharmacological treatment?
It is a very difficult question. You have two situations. The first one is the patient who's need initially a treatment. The first step is to obtain the expected response, often in 4 to 6 weeks. And then you have to check the control of the disease and determine if it is maintained or not. You cannot stop the follow-up before a cure has been obtained, or the diagnosis of cure may be very difficult in sarcoidosis. In patients who do not need treatment and where you see a spontaneous recovery, you can stop the follow-up easily. But in patients treated, you can have a relapse until 3 years and sometimes 5 years after withdrawal treatment. So you have to control follow-up with periodicity, with time increasing from visit to visit until every year. I think in cases with more severe disease, with important sequelae, even though the disease appears non-active, I think you have a whole life survey necessitated.
Thank you. Very difficult question, as you say. Another question that is gaining a lot of interest is, and Marlies touched on it, in more advanced fibrotic, progressive fibrotic pulmonary sarcoidosis, what is the role of anti-fibrotics such as nintedanib? What are your thoughts on that?
For now, there is no evidence at all, because in the study on non-IPF pulmonary fibrosis, the number of patients with sarcoidosis was very small. I think one very important point is to check that there is or not a resistance to treatment. And for that, the best test is to use the PET scanner. I think the PET scan is the best way to evaluate if there is still active lesions under treatment. A second point, very, very important in my experience, is to verify the observance of the treatment. Often, when I receive patients for resistance, these patients are not observant, and we need to spend time to check this point. I think the most frequent reason of failure of treatment in advanced sarcoidosis is due to bad observance. For patients with progressive fibrosis, despite no activity, PET scanners, the question of anti-fibrotic can be discussed, I think, in a multidisciplinary discussion.
Thank you, Dominique, and also for raising this issue of compliance, of course. You have lots of questions. We'll try and get through as many as we can. Another one is, if hypercalcemia is the only evidence of sarcoidosis, is there any alternative to corticosteroids?
I think it depends. Excuse me. It depends on the level of hypercalcemia. If the hypercalcemia is higher than 3 millimoles, I will give steroids, but in function of the cause of the hypercalcemia, the treatment will be short or long. Often when you have an hypercalcemia, you can have also a renal localization. And in a study we had some years ago in medicine, 1/3 of patients with renal sarcoidosis had hypercalcemia revealing the disease. On the other hand, in most cases, there is no renal sarcoidosis, and sometimes the hypercalcemia is due to taking vitamin D supplementation. In this case, I stop vitamin D supplementation, and often after a short course of steroids, I will stop the treatment, but I will survey the calcemia for a long time. And I will give recommendation with protection against the sun, for example, and to avoid eating excessive milky products, because sometimes you have people who enjoy eating cheese, particularly in France, and sometimes it is easy to control that. There is another group of patients who have hypercalcemia revealing sarcoidosis, which is severe for another reason. And in this case, you treat not only the hypercalcemia, but also the sarcoidosis. So you have very different situations. And one non-uncommon one is when hypercalcemia is light. For example, 2.80 millimoles. And in this case, often simple measures are sufficient.
Thank you very much. Another question regards, what would you do with a patient who only shows radiological progression of pulmonary sarcoidosis? So on X-ray or CT, it is worse, but no symptoms and normal lung function. Would you introduce treatment with corticosteroids, or would you monitor? What is your take on that?
In such situation, I will not give any treatment, but I will have a discussion with the patient to explain the importance of a very tight follow-up. Because sometimes when there is no treatment, the patient considers the disease is not important. And so I explained that for now, I prefer no treatment, but there is a risk to need a treatment in a second time.
Okay, and then I've got a couple of questions on biomarkers. One is, do you measure serum ACE to monitor disease activity? And the second one, do you ever use biomarkers to guide choice of treatment?
The question is for Marlies or me?
It is for this section, but anyone can answer.
In my practice, I have often observed that serum angiotensin converting enzyme is often elevated when there is a need for treatment. So I think it can help when you dose serially SACE. It helps in managing the treatment to give the lowest dose possible. But it's perhaps a personal opinion, which is very different from many people.
Okay, I don't know if we have time for a final question, and that is just about the indications to heart or lung transplant in sarcoidosis, as we haven't talked about transplant at all. What do you think about that? What are the key issues you think about when considering when to consider lung transplant?
First,
difficult to finish.
Yes, I think transplantation for the lung and the heart are essential in far advanced disease to avoid death. Results after transplantation are rather good, excellent for the heart, and as good as possible for the lung. The question is to propose to the right patients at the right time transplantation. I think when you have a severe pulmonary hypertension with no response with anti-inflammatory drugs, the most frequent situations, it is a very good indication for transplantation. Also, when you have advanced fibrosis with important physical limitation, you have to control the absence of contraindications. What is very fascinating in patients with sarcoidosis who are transplanted is that despite often very low immunosuppressive treatments, there are no more complications that than in patients with, for example, lymphangioliomyomatosis.
Thank you, Dominique, for very exhaustive replies. I'll pass over to Athol for the conclusion.
We're going to conclude by asking each of the panelists, followed by ourselves, to make a closing statement of the single message they feel is most important in their area today. And I'm going to go in the order of the speakers to allow Dominique to recover from fatigue. So I'm going to start with Vasilis.
I would say that it is important to consider multidisciplinary approach in every cardiac sarcoid patient for both diagnosis and management. Remember that this is a major organ involvement and you need to treat adequately, and always remember about the comorbidities as in every other sarcoid patient.
So it's a nice closing statement because there are absolutely no studies on multidisciplinary evaluation of cardiac sarcoid, but do watch this space. So Marlies.
I think the important thing is don't overtreat, don't undertreat. So individualize your approach for each patient. There are absolutely no studies to say what is over and under treatment, but watch the space. I would reiterate you and talk with the patient, you know, discuss and weigh the balances with the patient.
Dominique.
I would say that the most important during the follow-up is the clinical survey, not only chest X-ray or CT scan or pulmonary function. You have to hear your patients to know how he feels and how he tolerates his treatments and how he takes his treatment. And often at the end, I say, and what else? And in what else, the patient can give you other informations which can impact the disease and the treatment.
So, Dr. Renzoni, Elizabeth, what would you like to say to close?
That I have very much enjoyed the presentations and the Q&A session. And what I'm getting from it, from all of our speakers, is the importance of speaking with patients, of listening to patients, and on deciding as much as possible together with patients.
Well, I thoroughly enjoyed watching three people interrogated at great length, and congratulations to all panelists who've done a magnificent job. I think my overriding message is that in sarcoidosis, there is no one-size-fits-all in really any of the domains we've discussed today. We would all like one-size-fits-all, but whether you're talking about multidisciplinary discussion case by case, you're talking, Marlies, about the balance between over and under treatment, highly individualized, and the messages that Dominique is getting for his patients. Sarcoidosis has to be individualized in all things. So with that, which is merely a repetition of what our panelists have said very eloquently, I pass this back to you, Maeva.
Thank you. Thank you, Professor Wells and Dr. Renzoni, for chairing this event. And thanks to our speakers for sharing their knowledge with us tonight. And of course, thanks to our online participants today for joining us and for your many questions. A recording of the discussion will be available to rewatch on the ERS Respiratory channel. And the ERS Vision Live series will continue. A new live discussion panel will feature on the ERS Respiratory channel each month, bringing together key individuals to discuss hot topic areas within respiratory medicine and science. We hope you can join us again in July.